Dr. Nabors is a very good friend and has lectured extensively for many years to numerous universities, numerous dental state meetings and associations and physician groups on the subject of oral systemic link, molecular diagnosis, and its practical application to periodontal, peri-implant disease, genetic, risk management, classification, and therapy. His interest in microbiology, genetics, and molecular diagnostics spans 30 years. His experience in the clinical application of DNA PCR, which is a nucleic acid polymerase chain reaction test, and the founder of the molecular diagnostics CLIA certified clinical laboratory, makes him uniquely qualified as an educator. He's published numerous articles relating to molecular diagnostics, its clinical application, and the use of whole saliva as a diagnostics platform. Dr. Nabors saw the need for earlier and more accurate disease detection and management for periodontal infections. And with the advancement of molecular diagnostics in medicine, he founded Oral DNA Labs, Inc., with the help of an experienced team in 2008. Today, he is retired from Oral DNA, is not affiliated with the company. However, he continues his interest in helping dentists and their teams apply the advantages of molecular diagnostics to the benefit of their patients. Help me welcome Dr. Tom Nabors from Nashville, Tennessee.
Thank you. Thank you, Lee. Appreciate that very much, and thank you for being here. Lee, he does say he needs some light up here, so see if we can do that, and then also see the slides. Okay, can you see the slides okay? Good. I'm really excited to be here. To see this kind of support when those of us of like mind but have different jobs come together like we have in this organization, it is extraordinary. The only time I ever spoke to a combined group in a community was in South Carolina, where physicians and dentists come together once a year to actually share new information. Of course, AOSH is doing that too, which is very unique for all of us. I had an opportunity to speak to the dental hygiene school yesterday, and many of them are here, back here on the right, and I applaud them for their choice of educational experience. And I thank Lynn and the work that she's doing and her instructors in the wonderful work they're doing to prepare these young people for an exciting life event. My interest in periodontal disease goes back almost 50 years. I've been a dentist since 1968. And what I found in 1983 is they were doing things different at NIH than we were doing in our clinic. And what I also experienced in my life is that some of the things that we were doing did not achieve the end result that I had hoped that they would achieve. And thus, by looking at infections differently, I determined that we could do a better job of serving our patient base. And that's really why we're all here, is because we really want to understand how we can serve the people that are important to us, whether it be our families, whether it be our patients, whoever they are. And the subject title that I have today is very appropriate, and I want to try to tie in some of the wonderful information Amy Doneen and Chip presented this morning. And I'll just say on a side note, I had an opportunity after building the laboratory to meet Dr. Bale and Amy Doneen about 5 years ago. We've become very close friends as a result of that. And my topic today is oral pathogens, genetics, and of course, the central topic of inflammation. And the subtitle there is the oral connection to systemic disease. I want to mention salivary diagnostics because it is on our radar. It's been on our radar as dentists and as hygienists now for about a decade. And we keep hearing that in 3 to 5 years, we're going to have diagnostic tests. I've been hearing that for the past 15 years. So in 3 to 5 years, we never had any test that we could actually use. So I determined I would retire from my practice in 2006. And along with the help of my 2 sons and a very experienced team in the clinical laboratory world, including physicians, laboratory individuals, hygienists, and an entire team, we built Oral DNA Labs. And as was stated, I'm no longer a part of that, so there is no conflict of interest. But it is important that we know today that salivary diagnostics, the ability for us to use DNA, the ability to use proteins, is changing the way that we see disease. And it's also bringing together the world of general medicine, oral medicine, and as is stated today, we are really talking about oral medicine. And one of the tests that I will be showing that you see today is a pathogen test. You'll understand more about how this is applied in the clinical world, periodontology, and why there are only a few number of microorganisms here. But with that, I also want to make some real practical application. As I mentioned to Lee earlier, I've changed my program 3 times since 8 o'clock this morning. After listening to Amy and also to Chip, I realized that we really need to apply some of the knowledge that they have helped us understand. This is my CIMT report. And the one thing I would say to every one of you here, regardless of your background, if you haven't had a CIMT, the most practical thing that you can do is find someone to do a CIMT. Either get it here or get it somewhere else. And the story behind this is that when Brad Bale and I became friends, and Amy, I flew to Spokane, Washington from Nashville, Tennessee to have their model presented to me. And when I did that, I had a CIMT. And at age 66, when I was there 5 years ago, at age 66, my arterial age was 68. That's not bad. I was just 2 years over my chronological age. This is a report from November of last year, and if you can read this, you probably can't. My CMT as of November of 2013, my chronological age is 71. My arterial age is 50. Do I feel 50? Actually, no, I don't feel 50. I feel 35. And anything that I could do at 35, I can do now. And I will tell you, the reason I show you this is that things are reversible. And so whatever your CIMT is, if you follow the model, you can reverse your arterial age. And I don't know how long I'm going to live, but I have an agreement with Brad, and that is that we would have a celebration on our 100th birthday. So he hasn't guaranteed that, but we'll see whether or not that works. But I show this to say that regardless of what we are and what we do, we need to follow through with what we've learned in this meeting. Very important. So what does clinically healthy periodontal tissue look like? Well, we are used to looking at what we call the clinical phenotype, and that is the clinical presentation. This is a photograph that my son did for one of his patients to just clearly show what healthy mucosal gingival tissue looks like. It's clear. It has a pink color to it, but if we look, we can see the blood vessels very, very nicely. We can see the clinical attachment very nicely, and this is a completely clinically healthy individual. So, what does it look like microbiologically? Why is that important? Because those are the goals. The goals today are to achieve clinical and microbiological stability. If we have not achieved microbiological stability, we will have a reversal of disease, as the question was asked. How do we prevent PG from coming back? First thing is we have to know we've gotten rid of it. And so we're going to show you antimicrobial models, if we have time, that can help us achieve an end result that is better than what we've achieved in the past. So what does a biofilm community look like in healthy individuals, and how do we know that this is true? When our laboratory, very early on, we began an experiment of testing the healthiest mouths in the United States to determine what health looked like biologically. And guess who has the healthiest mouths in the United States? 22-year-old dental hygienist. Is that right? But by the time dental hygienists get into their 30s, we notice a little bleeding. By the time dental hygienists get into their 40s and 50s, they have more bleeding too. So it doesn't mean that we can prevent disease forever, but it does mean we can control disease and even reverse disease if we know the biological picture of the disease. And so as we look at a healthy individual looking at a DNA analysis of these particular microorganisms, there's no red complex, very little orange complex, and there is quite a bit of green. Green is actually good. Green represents 3 Capnocytophaga species that are associated more with health than disease. Typically see these go down in infection and that they will go back up when the infection is taken care of. So this is a perfect example of an individual that's not pathogen-free. There's a little bit there. In fact, we don't want them to be biologically sterile because we want them to have the nice flora that maintains health. One of these days we'll have a test that measures health bacteria, but this is what we have today based on pathogens. So what about the clinical status of an individual that comes to your practice today that looks like this? That looks pretty healthy clinically, doesn't it? There is radiographically no bone loss here, but what happens if you place a probe between number 7 and number 8 and you see this? Is that still healthy? There's no bone loss, but we can clearly see that this isn't healthy. So what do we do for this patient differently than what we've done in the past? Is it just a brushing and flossing problem? Is it just a prophy? Or do we change the conversation? I suggest to you when you see an individual that looks like this with no bone loss but has this type of bleeding with this microbiological profile, this is an infection. From what you've heard today, this individual is not only at risk for bone loss, as we can show from clinical trials based on odds ratios, but this patient is at risk for severe arterial inflammation. AA is present, PG is not, TF and TDR, very high levels. These are the invasive forms of oral pathogens that we should be concerned about because it ties the link between progressive periodontitis and also the link between chronic inflammation. So individuals always start out with early disease. They never start out with 5-millimeter pockets. In other words, the infection always occurs before anatomical changes occur. So we have to know very early on not only who's at risk, as Amy said later, we don't really, risk factors are great, but risk factors are not determining what cause is. And if we don't know what cause is, what causes disease, what causes atherosclerosis, what causes periodontal disease, then we are missing a very important part of the science because the science is telling you and it's telling me that we know what causes this shift in microbiological flora. And these are the ones that we know today based on certain information. So our program today is going to look at metagenomics, oral dysbiosis, oral pathogens relative to periodontitis and periimplantitis, vascular dissemination of oral pathogens, which is going to include a short presentation on intracellular invasion, oral pathogens relevant to atherosclerotic vascular disease, and we will try to throw in, if we have time, some practical application of case studies looking at these. So, metagenomics is a relatively new term for me. It might not be for you, but it is for me. And I began to study metagenomics a couple of years ago because of its close relationship to what we call biofilm. And metagenomics is the study of collection of genetic material or genomes from a mixed community of organizations and the influence on body function. So what it's just simply saying is we now know that microorganisms play an extremely important part in whether we are healthy or whether we are unhealthy. I was listening to Professor Trevor Marshall in this presentation in Granada, Spain in May of 2012, and he was looking at chronic inflammation, and he's a specialist in chronic autoimmune diseases. And what he is saying here is that the lines between chronic inflammation, chronic infections, and autoimmune diseases are being blurred, and that much of the top two are being driven by chronic infections. And therefore, we need to understand why microbes make us genetically unique. While we have 25,000 human genes, on bacteria alone, we have greater than 1 million bacterial genes. What is that? That's epigenetics. We have our own genetic pool, but we also have an epigenetic pool that is being controlled by the bacterial content of our mouth and of our GI tract, of our urogenital tract, of our skin, of our nose, of our ears. All of those are extremely important, and that's not counting viral and fungal genes. We don't know that much about them yet. But the influence of microbes and their combined genetic influence on health and disease is just beginning to be understood. And the last thing that he said, it is big. And why is it big? And how do we know that it's big? Well, we have to understand a little bit about the microbiology of health and disease and new systems such as next generation sequencing technology, where we are looking at the DNA of large masses of bacteria and their interspatial relationship and how they change their own genetic influence and how they drive human genetic influence is beginning to be studied. And so micro-communities are active, and many chronic diseases appear to follow a shift. In other words, as we move from good bacteria to bad bacteria, we end up with certain diseases. And it's our job today to understand the patterns within these bacterial masses with species-specific genetic influence, how bacteria drive each other, how they work together, and how they survive, because it is about survival for them, it's about survival for us. And thus, this concept of shifting from good to bad is called dysbiosis. This dysbiosis occurs in 5 different areas of the body, but it is a shift from good to bad. And the questions that they are asking in these areas are, how do these shifts occur? When do they occur? What can we do about it? And how does a chronic dysbiosis in one body part affect the entire human? This is a perfect introduction to the important role of bacteria. And as we'll particularly talk about oral bacteria, we need to understand that microbes create great potential to cause disease. Microbes cause the most trouble when they interfere with cell DNA. What does that mean? That means when microbes invade human cells. The main point here is that when pathogens invade and persist in human cells, particularly macrophages, dendritic cells, human B cells, and so forth, the game is over. Because when they persist in human cells, they will control the expression of inflammation. And what happens, the microbes always win, and when cells are invaded by pathogens, microbes, these cells will survive for long periods of time, and it is a mechanism that the microbes use to survive. And when that happens, the level of inflammation rises, and the signs of clinical disease will also rise. So we need to understand a little more about this, and that's what our government has done. They allocated $182 million in 2007 for the study of the human microbiome. I've had an opportunity to consult with some of these universities as we look at this first phase of mapping the composition and diversity of human microbe communities. The 5 communities that we are mapping are the oral microbiome, nasal microbiome, skin, urogenital, and gastrointestinal. All of these have potential possibility of creating a dysbiosis. And what we really want to know in phase 2, which started in 2012, is diseases that occur in these microbiomes, such as sinusitis, ear infections, gastrointestinal reflux, or esophageal reflux, vaginosis, inflammatory bowel disease, and obesity, and periodontal diseases, how these diseases affect the rest of the body. And of course, our focus today will be looking at the metagenomic influence on human health and disease, and in particularly the role that oral bacteria play in this dysbiosis relationship. So I shifted this slide presentation in thinking that I might not be able to get to it to apply because of time, to show why this is important to all of us in the room. This is a study that was published in October of 2013, published in the Journal of the American Heart Association. And the title is, and this is the 5th INVEST study. I hope I'll have time to look at the other 4. Amy Doneen showed you 2 or 3 of the others on hypertension and on CIMT. Changes in clinical and microbiological periodontal profiles relate to progression of carotid CIMT, the oral infections vascular disease study of 2013. It's based on the background of the relationship between the change and the changes in clinical perio conditions and the microbiological status. If you notice the two ingredients here, it's not just the clinical side of perio, but it's the microbiological side of perio that's really important here. And they looked at 420 patients, followed them for 3 years, and during that period of time, they longitudinally recorded the change in perio status and the progression of IMT. And all of these individuals had the traditional adjusters, in other words, for vascular disease, as best we could determine. These were healthy individuals, all adjusted for the traditional confounders. They looked at probing depths of 76,000, 5,000 subgingival samples, big study. And they assessed the 11 known periodontal bacterial species by DNA checkerboard hybridization called etiological-based, putative-based, and health-associated. The only difference in the microbes that they tested for here that you can actually use in salivary diagnostics is they used 2 health-associated microbes as opposed to all 11 of the pathogens. So if you are using a test or are going to use a test, all of the microbes that they used in this study are the ones that you can actually test in your own practice. So I've gone to some of the conclusions very quickly here for the sake of time. It's the first evidence that improvement in periodontal status, in other words, treating these individuals that have a progressive atherosclerotic process, defined both clinically and microbiologically, is associated with less progression of carotid CIMT, or atherosclerotic vascular disease. And here's another important part. Even low threshold perio measures less than 3 millimeters correlate strongly with etiologic periobacterial and inflammation and atherosclerotic vascular progression. In other words, they followed these individuals for 3 years and they could map the progression of CIMT changes of those that were not being treated. And based on the fact that they didn't have any other risk factors for progression of carotid atherosclerosis, those that had these bad bugs that we call red complex or etiological based, the AAPGTF and TD species, you could track the progression even in this short period of time. Of particular note in this particular study is the dose-responsive relationship. What does that mean? It's quantity. All of us will have certain species of organisms that have potential to cause disease, such as Staph aureus. All of us sitting here probably have a few of those in our nose, in our ears, and yet we're not sick. There are certain things that do happen in this dysbiosis, and one is the overgrowth of bad ones as opposed to the overgrowth of good ones. And when that happens, then we have a bad biofilm community. And it doesn't take many of the species to change in order to create that. So higher concentration of AAPGTF and TD showed more pocket progression, in other words, more periodontal disease, and more IMT progression at the same time. And even probing depths of 3 millimeters, here's something that's really a paradigm shift for those of us who are in the dental community, because we always thought that 3 millimeters was a symbol of health, didn't we? Even 3 millimeters should not be considered comparable with health or compatible with health. If you have these microorganisms, you have to really be very active very early, because individuals that did not have attachment loss also progressed with their ASVD. So the probing depth of 3 millimeters should not be considered compatible with health when we're comparing the relationship of this oral systemic relationship. The study emphasized the importance of primary periodontal care as a possible preventive health measure. And so it sort of, just summarizing this, they found that if there was a worsening periodontal health based on the etiologic-based bacteria, there was a concurrent worsening IMT progression. However, they also showed that if they treated the periodontal disease and eliminated those 4 microbes, they saw a decreased rate of IMT progression. And the predominance of bacteria traditionally considered causally related to perio disease was closely linked to that. And I will just kind of mention only the bacterial exposures remain statistically significantly associated with IMT progression. So if we're trying to do studies, and that's one of the problems we've had in combining the studies of the oral systemic leak, was because many of the early studies looked at clinical progression of periodontal disease and not the biological progression of disease. Now we're understanding that it's really the bacterial dysbiosis and the influx of these bacteria into the arterial system and into the invasion species and into the endothelial cells, into the macrophages and the dendritic cells where we drive massive amounts of inflammations. This was an article that was published in The Economist magazine in 2012 after learning of the Human Microbiome Project. And this is really becoming a significant part of medicine today. Microbes make it the man. So as we are observing the changes of medical care using the Human Genome Project, completed in 2003, we're looking at variations of human DNA. It can be slight variations and increased risk. We're looking at pharmacogenetics that change personalized care. And that's the secret of medicine today when we are treating and preventing disease, is looking at individuals as opposed to large numbers and treating individuals as individuals. And that's what the Human Microbiome Project is accomplishing to do too, which fits very well with our ability now to measure these microorganisms. So we have human the microbiome. We now are understanding the DNA of these microorganisms and their association with many forms of chronic infections. We're also now combining the relationships between chronic infections and health and disease, and now we're able to deliver more personalized care, whether it be periodontal disease or whether it be gastrointestinal disease. Once we discover the shifts and reverse the shifts, then we can end up with better outcomes. So trying that specifically, as we've looked at a large view of the human genome, it's important that we understand the microbiome of the oral cavity and in particular periodontal infections. It is a very common form of infection, and as has been stated earlier, we understand the putative pathogens of disease, which primarily are here. How do we know that? Well, based on decades of virulent factor studies, we know that these are different than the others. We know that the virulent factors here are different than these, and these have very few virulent factors, in fact, are more stabilizing microbes. So we have had studies now for at least 2 decades understanding the virulent factors associated with different microbes in the mouth, meaning that not all microbes are created equal. And I would suggest to you also that microbes that get into the wrong place tend to cause disease as well. So we want to keep microbes that are healthy in the right place, and the specificity of disease really does matter because it changes the cellular. I don't think I have a lot of time today to talk particularly about molecular level and how we can demonstrate the inflammatory pathways at a cellular level, but I will touch on that just briefly. But what we want to know about periodontal diseases is that they are different and that there's a wide range of illnesses, and that's the first time I've ever seen the word periodontal disease described as an illness in literature today. But I think we need to start thinking that way. Periodontal diseases are a chronic illness that range from mild gingivitis to severe periodontitis and even to life-threatening diseases. What do you mean by that? Well, here's a periodontal disease patient in the 20s. Here's a child with periodontal disease. Yes, children can have periodontal disease. Here's an older person with periodontal disease. Here's a middle-aged person with periodontal disease. And here's NOMA. This is periodontal disease in the African continent. When you add PGTFTD and several others such as FN and PI, and then you add Borrelia that comes from ticks, and then you add some genetic sequences that are slightly different, you end up with life-threatening diseases that literally eats the face away of these children and these adults. If they ever live to be adults, they will be disfigured, but most all of them die. And it's the same polymicrobial infection that we call periodontal disease here in our country. And if you were to isolate the causative agents of this, you would find the same DNA analysis except for a few others. So NOMA is a life-threatening disease. Fortunately, we have antibiotics in our country, and we treat periodontal disease, and we have a little slight genetic variation, and we don't have quite that much. I will just briefly touch on a couple of slides of why it's important that we understand inflammation at a cellular level and why it's important that we understand how our body recognizes the difference in microorganisms. All bacteria have a molecular structure that is called a pathogen-associated molecular pattern. In other words, the outside of the bacteria has a pattern. all of our cells have little antennae that are called toll-like receptors. And the toll-like receptors have the ability to differentiate between the molecular patterns, whether they be good or whether they be bad. And with this knowledge, in other words, this is blown up here and it looks like a little key and lock and key effect. They kind of join together. Microorganism can invade if it has the capability of that. But the most important thing that we need to realize is that it's the molecular pattern of the microorganism that is recognized by the toll-like receptor that drives the type of inflammation that is going to occur. In other words, is it going to be bad? Is it going to be good? Is it going to be long-lived? Is it going to be short-lived? Is all determined by initially this relationship. So microorganisms that have a flagella are going to be recognized by a different toll-like receptor, and it's also going to signal a different inflammatory pathway. This is how sophisticated the knowledge is about understanding the role that specific bacteria play in the role of inflammation. And these are little microbial sensing proteins, and a single dendritic cell or macrophage can have as many as 100,000 toll-like receptors on a single cell. So it can determine different species and different numbers in a very short period of time. But what it does, it transforms the response to infection. Specific molecular signatures, unique, and it activates the nuclear factor kappa beta pathway, which is very responsible for linking the innate and adaptive response and by the production of IL-1, 6, 8, tumor necrosis factor, IL-12, and RANTES. So we know now that even in early infections that certain microorganisms turn on systemic inflammation even in less than 3 millimeter pockets. You don't have to have a 5-6 millimeter pocket and have chronic inflammation. In systemic, it can happen in less than 3 millimeter pocketing because now we know the bacteria that drive inflammation. So there are things that we need to know as dentists, things that you need to know as physicians, as nurses, as dental hygienists. And we need to know that bacteria are good when they're in the right place and that they are of the right balance. But that balance can tip. It can tip relatively quickly, and there are multiple things that can change that balance. But these are some factors and principles of bacterial infection that we need to understand, whether it's a life-threatening infection that occurs, such as Staph aureus, or where it's a chronic infection that occurs over time. And these are time-type infections that we're talking about. So we need to understand microbial virulence. You don't need to go back, become a microbiologist to understand that. All you have to do today is read a report. So we didn't have a report that we could use as dentists. We didn't have the clinical laboratory model up until 5 years ago. You guys that are physicians have been using laboratory reports in the day that you got out of, when you were in medical school or when you were in nursing school. And the reason that I wanted to have a laboratory was just for that purpose, because I knew that we had disease and we couldn't measure it biologically, and we need to have clinical reports that a physician could use, or a nurse could use, or a hygienist could use, or a dentist could use, and we can communicate at a level that's based on what you are familiar with, and that's a clinical laboratory report. Clinical laboratory reports are the way that physicians communicate with each other. It's the way they communicate with their colleagues, the way they communicate with their patients, and 70% of the treatment is driven by clinical laboratory reports. We now have clinical laboratory reports that can help us understand these infections. So the report is going to already give you this information. It's going to tell you which ones are the most invasive. Now, the report will tell you also amount, and it won't tell you anything about the body's defense, but you're going to know just from the other that it's important to know. So of the, let's say, 700 to 1,000 different species that occur in the oral cavity, which ones are the good ones and which ones are the bad ones? That's been the trouble. And prior to DNA sequencing and using DNA PCR and next generation sequencing, we didn't have the ability to do that. We couldn't grow some of these microbes, and even if we could, we couldn't differentiate one from the other. And it's the DNA patterns that now gives us the ability to do that. And as we look at the studies that are ongoing, this is perhaps the best. It's a 10-year study published in 2006, looking at several hundred patients for long periods of time. And when we look at the microbes that are on this particular list, it's the ones in the red circle that have the most data. In other words, based on virulence factors, based on their presence in pocketing and so forth, it's these microorganisms that give us the most information about dysbiosis. We used to call some of these consensus pathogens. The new literature today called them keystone pathogens. Why do they call them keystone? Because it only takes one of those in sufficient concentration to change the entire DNA expression of the mass. It only takes one of those microorganisms in sufficient quantity to change the entire DNA expression of the mass. So we need to know, and we'll learn more as time goes on, which bacteria are most important. But today, this is what we know, and those microorganisms are on the reports, whether they come from oral DNA labs or whether they come from Germany in the form of Hein Diagnostics labs. That's your preference. But you now have the ability to do that. The new definitions of periodontal disease are designed around the new understanding of inflammation, and that is that gingival and periodontal lesions are the result of bacteria-induced inflammatory responses resulting in innate and adaptive arms of the immune system. And that's what we need to understand as clinicians, is that these are not just bugs that affect the teeth and the gums, but these are ones that get into the arterial system and that drive systemic inflammation via infecting the endothelium and also infecting the macrophages and dendritic cells. So even in early disease or late stage disease, we need to understand where the patient is based on their potential for having progressive periodontal disease or losing implants or having systemic inflammation. So Tom, that was 2006, but haven't we learned more than that in the past 8 years? Well, here's a study, 2014, looking at 6,300 individuals, looking at DNA analysis of gradations of healthy patients to periodontitis, and it looked at not only bacteria but also the interbacterial relationships, and guess what? It's the same bacteria that we looked at in 2014 that we looked at in 2006. So we're still on target. Now we could have a little variation in the reports, but it's not that particularly necessary. What about implants? Those of us who are placing implants or treating implants, all of us have contact with implant patients in our practices. Be aware the increase of these for high-risk bacteria are the ones that also are responsible for most implant infections. And as we look at textbooks that talk about treating implant infections, it clearly says that microbiological testing is significantly important in understanding the disease at an early point in time. Thus, there is a considerable variation in composition of subgingival bacteria between individuals. So why is that important? Well, the question was asked at the European complexity. It was called the Periodontal Infections Understanding the Complexity Consensus of 7th European Workshop in 2011. And they were asking the questions, okay, so does it really matter that you have different species and different infections? That's the question. Well, we have cross-sectional studies that clearly show that different microbial profiles are associated with distinct host tissue responses, even in tissues with similar clinical presentation. That explains to us why some of our patients that have the same clinical presentation don't do as well as others. Let's look briefly at this. Oral bacteria differ in their ability to induce inflammatory responses in human monocytic cells. So how can we show different bacteria actually change the expression of inflammation? So what if we infect human monocytes with the DNA of PG, TF, and FN, or the DNA of Strep sanguinus, which is health, or whole bacteria and LPS from PG? Now this is metagenomics at the closest level to our understanding. This is at the cellular response. So what did they do? What was the aim? Because this is important for all of us, regardless of what our specialty is. And that's to determine the cytokine production from human monocytes, or THP1 cells, and particularly looking at IL-1 beta, IL-6, IL-8, and tumor necrosis factor alpha, which are all acute phase pro-inflammatory cytokines. And all of these inflammatory cytokines are produced by antigen-presenting cells and T cell response, their first phase, and also important in the physiological regulation of many biological. In other words, they're important. And yet, in chronic infections, they are produced at levels that have pathological consequences. So when these cytokines are produced at levels that are above norm to defend us but actually become pathogenic in their expression, in periodontal disease, they cause different levels of colon destruction and bone loss. In diabetes, they cause beta cell death and insulin resistance. In vascular disease, they cause or contribute to vascular inflammation and endothelial dysfunction. So all of those are important to all of us, whether we are dentists or hygienists or physicians or whatever. And so the point that we make here is yes, and we ask the question, are different microbes pathogen specific? In other words, are they more or less able to express these different cytokines? So if we introduced a series of human monocytes with a strep species that is considered to be a health-associated species, and we look at the expression of these cytokines, these 4 cytokines here, we noticed that in a non-pathogenic species in the mouth, you see little or no expression of these inflammatory cytokines. Everybody see that with the horizontal line? But if you introduce PG, in other words, just the DNA strand of PG to the monocytes, look at the expression of IL-1 beta, IL-6, IL-8, and tumor necrosis factor. If you introduce Fusobacterium nucleatum, look at the expression of these 4 cytokines. So different microorganisms cause the human immune system to express different levels of inflammation. So it certainly does empower us to understand why it's important to know what's there. So look what happens, though, in the world of metagenomics when we add a lipopolysaccharide called LPS to the mix. Look at the top line. So we are now adding the whole Porphyromonas gingivalis, including their external structure, which is an LPS protein. And look what happens to even Staph sanguinis, which is considered to be non-pathogenic. But when you add a pathogenic protein such as LPS to even a normal, healthy bacteria, it becomes pathogenic in its expression. Does everybody see that? Look what happens, and this is called the metagenomic influence of certain microorganisms into a world of a biofilm community here. So the conclusion here is that different microorganisms do express different rates of inflammatory mediators, and that the pathogen species that we call high-risk pathogens do excite all the immune cytokines while the non-pathogenic species do. But when you add the LPS to the mix, everything really becomes pathogenic. So it's not good for us to have the immune system turned on all the time. And so as dentists, we can't assume that we know what's there when we're treating these patients. And we can't assume that we've accomplished the goal. This study was done in 2004 by Beichler and the group to determine, well, what if we looked at 6 pathogens in 771 individuals, and what kind, and I know the argument here is, well, we all have the same microbes, and we all have them pretty much in the same combination or the same quantity. And this study clearly showed that that's not the case, because when they looked at these 774 individuals, what they found is that there were 46 different combinations of bacteria in individuals that had similar clinical findings. And they broke it down into what they call 9 pathogen complexes being most prominent and 37 minor pathogen complexes. The whole point is that when we have infections or when we have a dysbiosis that is occurring, it's an individual scenario. It's not an epidemiological scenario. And we need to understand on a personal level. Chronic inflammatory disease are many kinds, and if you look at some of the, I just Google chronic inflammatory disease and look at that whole list, and guess what? Periodontal disease isn't even on the list. And it's a chronic inflammatory disease that is found in most of the population. So where does it all start? It starts right here. Here's the tooth illustration. Here's the tissue. This is the epithelial attachment here. And here's a healthy mouth. You see, this always happens before this does. When this dysbiosis begins to occur, there's an inflammatory reaction that begins to occur too, and we do end up very quickly with this. Now, we don't know at this point in time, because clinical signs are not good predictors of the progression of disease, we don't know what's going to happen here unless we know what's in here. because if we don't know, we could end up with this, and we could end up with this. And so it all starts there, and the earlier that we have a chance to look at that, the better off our patients will be. Well, we understand today, going back to the topic of invasion of dental biofilms and the growth patterns, the maturing phase of growth patterns. In fact, I would suggest to you that our job is not to kill all the bacteria in the mouth. In fact, that would not be a good thing. Our job is to rebalance the mouth so that we have more good bacteria than we have bad, and teach our patients how to maintain that balance. But our job, first of all, is to make sure that we are creating that, and to make sure that we have none of these bacteria that are residing at detection levels. We may have a few, as we may even have some Staph aureus, but we want them at very low levels. And we understand now the importance of invasion, and we understand the pathways they create and the differences. And what we know today, that these microorganisms here have been identified, and they are the ones that you can actually test for. And so the point I would make is we spend most of our time in periodontology on treating the teeth and the calcified matter here and removing plaque and so forth, but the real bad ones are here. They're the ones that colonize in the tissues. And most of the reason that our patients refract and they end up with disease is because, number one, we were not able to achieve the end result that we needed to achieve. We created a great end result of removing calculus and plaque, but we did not treat those that are in the tissue. And that's where the high-risk bacteria are. They reside in tissue, not on teeth. And so our goals of therapy today, as we look at the literature of all the different models of treatment, whether we're using lasers, trays, scaling and root planing, antiseptics, antibiotics, or whatever, our goals are the same, and that is to promote a shift from predominantly pathogenic to host-compatible, and then secondly, to achieve microbiologic and clinical stability. So this is new for us. So here we have a typical perio case to show you some examples of that, where we have the chronic signs of inflammation, and here we have a report. So here we have clinical instability, and here we have microbiologic instability. So here we have post-therapy clinical stability based on clinical signs, and here we have microbiologic stability. So here we have a perfect scenario where we have changed both the clinical presentation as well as the biological phenotype. I think everybody can see that. So is this patient healthy clinically? We would all agree yes, because we've done all the clinical exam, no bleeding, so forth. But now biologically, we have shown, see, that we changed from here to here. Huge change here. We have gone back into balance. Are there a few orange complex, moderate risk pathogens there? Yes. But in this particular patient, this is fine. This is balanced. Can we maintain that? Well, that's a question that we'll have to evaluate as we look at patient to patient, because they're going to have a job to do that perhaps is a little bit different. And some of the things that we will have them do for an extended period of time is rinse with antiseptics or irrigate with antiseptics for at least a month, then reevaluate, retest, and find out where they are, and then determine what the long term is. This is one of my patients back in the late 90s. And this patient, as you can tell, came in to get what? His teeth cleaned. And we see that every day, don't we? And yet when we saw this, we knew there was something more, and that we have a real periodontal problem here with 5 to 6 millimeter probe depths, lots of bleeding and so forth. And he came in because his girlfriend said he had bad breath. And so I can see why he would have bad breath. So we treated this patient, saw this patient 6 different times. Scaling and root planing, scaling and root planing, scaling and root planing, home care, home care. Saw this patient 6 different times. And here's what this patient looked like on his 1-month follow-up. And never let your patients go more than 3 to 4 or 4 to 6 weeks post-treatment, because you want to reevaluate at that point in time. Well, gosh, he looks a lot better, but he didn't look good. We could all say, well, gosh, clinically he's better. So clinically your CRP is 3 and it was 6. Have we finished? Hadn't finished yet. We hadn't gotten there yet. How do we know we hadn't gotten there? Because here's his clinical laboratory report after 6 appointments of scaling and root planing and using povidone iodine as an irrigant in post-therapy, during the treatment phase. We were doing everything we knew to do for this patient at that point in time. Yes, question? Very often you can see these reinfections from members of the family. Absolutely. Treat families, don't just treat individuals of the families. Exactly right. Transmission is exactly right. But here's what I want you to see. Regardless of how good you think you are, make sure you validate that you're really good. And I'll tell you, this was the first case I ever did a DNA analysis on. It actually came from a different laboratory, and this is converted to the oral DNA. But I want you to show that even good people having good objectives can fail in the microbiological end result. Now, what did we do different? We used the report to determine that, yes, this patient is going to need a systemic antibiotic. We've done everything we could without it. We put patient on the right antibiotic for that right infection, and the report would tell you the correct antibiotic based on the infection. Don't always use the same. Use the right one. And here's what the patient looked like 8 days later. So now we have created clinical stability, and we have also created microbiological stability. Here's a question. Yes? In the process of the treatment, what phase would you place or initiate the systemic antibiotic therapy? That would vary on, number one, the medical history of the patient. If the medical history of the patient showed that he had heart disease or she had heart disease or a recent heart attack, I'd start the antibiotics 1 day before the therapy. Because I don't want to introduce, I want to reduce the number of microorganisms that I introduce into the vascular system, because I know when I start my perio treatment, I'm going to introduce a lot of bacteria. If it's a, quote, healthy individual where there is no medical history, I'm going to use this to tell me right here, these microorganisms. And I'm going to, if, let's say we want to be very conservative, then use the second report to determine if you can use antibiotics. If you bring the patient back for 6 RPs, what is the sequence on that? When do you put the patient on the antibiotic? If you're going to put the patient on the antibiotic and you know you're going to do that, then make sure you remove all the biofilm before you put the patient on the antibiotics. So do that at the last appointment. Because as we know, biofilms will not allow the antibiotic to penetrate the surface of the bacteria, of the biofilm, and you will actually be throwing away good antibiotics, introducing the patient to antibiotics they shouldn't have at the wrong time. So make sure that you get rid of the biofilm community, disperse them, antibiotics. In other words, MIC, minimal inhibitory concentration, that's the ability for antibiotics to get to the site and kill the bacteria. Yes?
In a case like this,
yes.
it's kind of refractory for topical therapy.
Yes.
And then you institute a systemic therapy. What frequency of recidivism?
In the case where you have this and you didn't use antibiotics, but you did because you didn't get the result, what kind of repeat or refractory recidivism would you have? If these patients would do what we teach them to do, and that is to use antiseptics every day because they are high risk, I would say it's extremely rare that they need to be on a second antibiotic. Extremely rare. But you're going to have to follow this patient closely. I would reevaluate this patient at least every year because of the history of the patient here. And reevaluate microscopically, you understand what I'm saying? Or anytime I saw a shift, because this patient's really high risk. And we would want to see that patient at day 30, and then 3 months after, 3 months after, 3 months after. On many of our perio patients, we changed literally to twice a year. Once we got the microbiology under control and we saw that they could maintain that, then we would shift from every 3 months to every 6 months, if that could happen, which was a good thing for them. So do we work, of course, with our wonderful surgeon friends? Of course we do. And here's a case that my son treated using an old DNA report. This is from Hein Diagnostics in Germany prior to oral DNA. This young lady here had this 3-unit bridge done 3 years previous. And at that time, the periodontist was helping the dentist, extracted this tooth and grafted this site. Obviously, you didn't have this wound right here 3 years ago, but now she comes in, has left that dentist because she has pus coming out of this area, it smells bad, she knows it's in trouble, and she looks like she's going to lose this. And the recommendation was, well, let's take this out and let's put 2 implants here. And then let's go on. Well, she said, well, gosh, I'm 22 years old. I don't want implants. And what's going to keep the implants in place if this keeps going bad? And so this is the report that he took on day one. Did everybody see that? AA is off the chart. PG is off the chart and so forth. I would also say, probably it just kind of hit me here, this is also a way of communicate with our physician colleagues, because when we see these high-risk pathogens here, particularly in certain individuals that have histories, we should also be talking to them about vascular inflammation and referring them to our colleague cardiologist friend, our GP friend, whoever that we are working with in our community to make sure that they are running the reports on their serum markers and their urine markers to make sure everything else is safe. If it's not safe, that we are working together. Everybody understand that? Because you remember when Amy was here this morning, she talked about all of this. When Dr. Whitney was talking earlier, they were talking about this. See, this is a way that we communicate with our patients and also communicate with our other colleagues as far as systemic inflammation is concerned. Bottom line is the treatment was to debride the entire mouth, and this was an antibiotic immediately because of the history here. Get the infection under control, which occurred, then do another bone graft, and also we had the endodontist involved because I see some of our endodontist friends here. This would be a prophylactic endobiotic treatment because of the extensive that and also some radiolucent area down here. Would you agree with that, endodontist? And so we did a prophylactic, they did a prophylactic endo treatment, bone grafted the area, and here is the post result. We have pictures of her now, 6 years post-op, and has never come back. The question sometimes is asked, and it was asked today, do these infections come back? Why do we do this? Why do we test? They're going to come back. Well, if we treat it correctly, they don't come back as often as we think they do unless everybody quits. In children, is it possible for children to have early periodontal disease? Absolutely. This is a young girl in braces that has inflammation rampant. And we would say, well, gosh, she's 12 years old, she's going through puberty, hormonal changes, she's not brushing and flossing. Well, everybody had tried that for a year, but she didn't get better. So she changed dentists, went to my son, said, and the mom said, what's wrong with my child? Why does her mouth look like this? The orthodontist says it's normal. My other dentist said it's normal. But is this normal? So let's do a test. So here's our report on a young girl that's 12 years old. No red complex, but we do have moderate risk pathogens here. So what would happen if we eliminated those in a young girl that had inflammation present for over a year, and if we use that as our targets? Well, this is what we end up with in a very short period of time. We can solve these problems. This is not a brace problem. This is not a brushing and flossing problem for her. She was also genetically IO1 positive. I don't have time to talk about the interleukin genetic link, but just simply mention there is one link that we know in genetic variation called the IO1 genetic variation. And about 30 to 35% of the American population is IO1 positive, meaning that they will overexpress the cytokine interleukin-1 beta and alpha if they are challenged with a bacterial infection. And those individuals have to be watched more closely because they will have more severe periodontal disease. It also drives more systemic inflammation. Dunn did a study of over 600 people looking at the IO1 genotype and expression of inflammation, drew a graph and showed that IO1 positive patients had an equal risk of having heart disease as a smoker, and even if the individual is a non-smoker. So the IO1 genetic expression, when challenged, it creates a massive amount of systemic inflammation when they're challenged with a bacterial infection. One of my patients, 68 years old, didn't want implants, came in with pain, swelling, pus coming out of this area. We can all see what's happening here. A lot of bone loss, so forth. Didn't want implants, 68 years old, said, can you help me? I said, well, let's try. Here he is 4 months later using the model that we're talking about here, and here he is 1 year later. This is all non-surgical periotherapy. I had planned to do surgery on this patient, but he was doing so well, we decided to just observe to see what would happen. And this happens more times than we ever thought it would be. I've had an opportunity over the years to have individuals call me from different parts of the country to consult with them on failing implants. And here we have a lot of failure here, a lot of bad bone loss, a lot of infection here, infection here, infection here. And I'd say, well, go ahead and test these patients because I don't know what you're going to do. I can't help you there. but I can at least tell you what's there. And this is what's here on this failing implant case. My thought pattern here, and this is what I did in my practice prior to leaving clinical practice, is that I would never place an implant or never restore an implant or never recommend an implant placement unless I had biological stability. That means clinical stability and microbiological stability, and I also wanted to know if they were I1 positive or negative. It didn't change whether or not we recommended implants, but it changed the way we treated the patient. These individuals that are I1 positive will have more implant problems, and also, if they are infected, they will have more problems as well. So that's important. So it's important that we look at biofilms early in disease as opposed to late. I'm convinced, and in fact, Bartol and Narayanan in 1998 in their book called Biology of Periodontal Connective Tissue said there are 4 phases or 4 events associated with the development of periodontal disease. Number 1, bacterial infection. Number 2, genetic response. Number 3, metabolic response. And number 4, anatomical changes. And where are we? We're at stage 4. See, we're treating late stage disease. As Amy or Brad would say, you're treating patients that already have had a heart attack. Or you're treating patients that have already had a stroke. Although we would not compare the difference between a periodontal lesion and a heart attack or stroke, we would compare the analogy. And that is that we have to determine root cause, we have to treat cause, and add risk factors, of course, that are in there. Here's an individual that wanted veneers. Here's some inflammation around here. The dentist decided to use lasers and do some laser recontouring for aesthetics. And here is the post-treatment. So here we have clinical instability prior to treatment of the beautiful veneers, but look at this tissue. The tissue is worse looking now than it was in the beginning. So the instability is worse after all that cosmetic treatment. So what's wrong? And so we ask all the traditional questions, and that is, where are the margins? And it's person allergic and so forth, but and certainly all that's important, but what if we just tested them? And here we find that there's 2 moderate risk pathogens that this individual had. Oops, I'm sorry, don't show the post-op. But when this was removed, this all went away. Same thing is true with severe cases. Here's a progression. The reason I put this in here, some people progress from health, very, very diseased, to not so much, to really, really healthy. So the relationship of going from bad to good sometimes occurs over time, and this is what I will leave you with, and that is, if we are going to understand the relationship between the mouth and disease, and if one of our goals is overall health and well-being, we need to always begin to understand in our world what infections are, because they always happen first rather than waiting. Of course, some of our patients are here before we treat them, but we still have to back up and determine what is there. I see that my time is up, and so I appreciate your attention, and if I can help you in any way, please let me know. Thank you very much.